Hello, everyone. I'm David Lillicrap from Queen's University in Kingston in Canada, and it's my pleasure to introduce to you a session today about the therapies, the landscape therapies for hemophilia. And I'm joined by Professor Johnny Mahlangu from the University of Witwatersrand in South Africa today. Johnny, it's wonderful to see you. I hear you've had snow in Johannesburg today. That's astonishing. That must be very difficult for you in South Africa.
Yes, David, you're absolutely right. Snow in so many decades, and certainly, of course, we are not as prepared as the Canadians would be for snow.
I saw some pictures. We would barely call that snow in Canada, actually. But anyway, it's different. So during this session today, we're going to talk about 3 areas of therapy for hemophilia. We're going to spend some time talking initially about replacement therapy, then move on to non-replacement therapies, and finish with some discussion about gene therapy. So, Johnny, this has been an astonishing 10 years for hemophilia. So maybe you could introduce us, first of all, to what's happening with replacement therapies in hemophilia.
Absolutely, David. It has been, and I always comment that we are lucky to be living in this era of unprecedented evolution in the therapeutic landscape in hemophilia. Starting with, of course, the replacement therapies, in particular the recombinant proteins, as well as the modified recombinant proteins, the so-called extended half-life products that we saw in the last decade coming to fruition. And many of these, in fact, we're using on a daily basis. And of course, replacement therapy has pushed us into elevating the standard of care in hemophilia to the level at which we have now accepted globally that prophylaxis is the new standard of care. And the replacement therapy, in fact, initiated that process. Replacement therapies, as you know, David, are not without challenges. And maybe we could talk about some of those challenges.
Yeah, I mean, around the world, the percentage of patients on the different forms of replacement therapy will differ, of course, but I assume, are you using still some plasma-derived concentrates in South Africa, or are they, almost everyone is on some form of recombinant therapy, many on extended half-life therapies, I assume?
Absolutely, David. In South Africa, in fact, strange enough, the majority of the patients are still on plasma-derived product. And the reason for that is largely around cost and affordability. Our plasma-derived product is locally fractionated. There's a long history, of course, of safety and efficacy, and therefore it has not been fair for the recombinant products be expected to compete price-wise with our plasma-derived product. Having said that, there is a fair number of patients in our country that are now using recombinant products and extended half-life products.
Right. But there are still the problems with the burden of therapy, for sure. I mean, the frequent infusions and the inhibitor problem, which is still a concern for us, of course, with hemophilia A. Do you have anything else to say about I mean, there's nothing much we can do about that with the replacement therapies. There's still about a 30% likelihood of previously untransfused patients getting inhibitors.
Absolutely. And in fact, you've summarized it very nicely, David. As far as I can see it, there are at least 3 challenges. One is the high burden of treatment associated with the intravenous infusion of replacement therapy. The second one is immunogenicity. You correctly point out, in the context of hemophilia A, up to a third of the patients will develop neutralizing antibodies against the replacement therapy. And the third one, and I think the one that we're beginning to appreciate now as we move towards non-replacement therapy, is the fact that the pharmacokinetics of replacement therapy is characterized by peaks and troughs. And we do know that even in the best settings where patients may be receiving regular doses of replacement therapy, The troughs are the areas where they are likely to bleed. These are the areas where, in fact, they are least protected. So the pharmacokinetics will be a third challenge with replacement therapy.
Johnny, maybe you could comment a little on these other. There are some very new replacement therapies that are in late stages of development, including a material called BIV001. Tell us a little bit about that.
Absolutely. I'm glad you asked the question, David, because it is a replacement therapy. Despite the fact that I pointed out the shortcomings of replacement therapy, I believe that molecules such as BIV001 has got the potential, in fact, to take us to the next level of hemophilia care. With this molecule, as you know, the frequency of injection is much, much lower. One is able to achieve a relatively high trough level, essentially meaning that we should be able to do effective prophylaxis for our patients without the risk of breakthrough bleeds that we see often with the standard half-life and sometimes the extended half-life products.
Great. So we're going to move on now to the area where I think we've seen the biggest expansion of innovation, and that's non-factor replacement therapies. And in the last 10 years, this has been an astonishing increase in the possibilities here. And the two major areas we'll discuss this morning are going to be factor VIII mimetic therapies, and then a group of therapies which rebalance hemostasis to the benefit of hemophiliacs. So they alter hemostasis in different ways that Johnny will describe.
Thank you, David. And again, one could ask, why would you want to develop non-replacement therapies when we've got so many replacement therapies? And I think they have the potential to address some of the unmet needs that I alluded to when we're describing the replacement therapies. As you correctly point out, we have the factor VIII mimetics, the prototypes being emicizumab, as well as Mimate, which is a second generation factor VIII mimetic. We can talk about some more details on those two. The next big category is the so-called rebalancing agents. In this category, we have anti-tissue factor pathway inhibitor. These are monoclonal antibodies that inhibit the inhibitor, which is the tissue factor pathway in hemostasis. And then we've got the antithrombin, the small interfering RNA directed against the antithrombin, as we saw recently published in the Lancet and Lancet Hematology, the two phase 3 studies describing a very positive outcome of the safety profile as well as the efficacy of the prototype molecule here called fitusiran. And the third category is the activated protein C, in which, in fact, we're still very early in the development of these molecules. Just going back to the anti-tissue factor pathway inhibitor, we've got two molecules there, mestacimab as well as concizumab. Mestacimab is currently in the phase 3 stage of development. Concizumab, in fact, is not registered in Canada for the indication of hemophilia B patients with inhibitors, which, as we know, in fact, is got the highest unmet need.
Yeah, these advances are remarkable. They all are given subcutaneously. So all of these therapies that John has referred to have the convenience of infrequent subcutaneous delivery, which obviously for patients with hemophilia who previously have been giving intravenous infusions, often several times per week. And the other thing about the factor VIII mimetics is that there's very good evidence that they work equally well in patients with anti-factor VIII antibodies, factor VIII inhibitors. And so this group of patients who are otherwise extremely difficult to treat now have a way of prophylaxing, preventing bleeds. although they may need to be treated with bypass agents for bleeding episodes. And as Johnny has said, there are now second and soon to be third generation factor VIII mimetics coming. So this is an area, I think, of great expansion, interest. Some of these therapies are almost in the clinics. They've undergone phase 3 studies, and it's an area to watch. Complications, Johnny. I mean, they're not without some complications. Maybe a word or two about what we need to watch out for, especially with the rebalancing agents.
So, David, I mean, obviously, prize number one in the development of these molecules, we will not accept anything other than an acceptable safety profile. They have shown, at least have been shown in a number of phase 1, phase 2, and some of them phase 3 studies, that the safety profile is actually acceptable. And of course, they do what we expect them to do, and that is to prevent bleeds. The challenges with some of these molecules, and in fact, I'll allude to maybe one or two of those, is that one cannot monitor them for a variety of reasons. So monitoring is probably something that one will need to rethink when we are using rebalancing agent. And in part, it may be that it's not possible to measure, for example, tissue factor pathway in the system. And the other sort of challenge may well be that these molecules are only used for prevention of bleeds, but they are not used for the treatment of bleeds. And one obviously needs to start looking at some of these molecules being developed further to be used both for acute treatment of bleeds in addition to the prevention of bleeds. And of course, there is already some thinking along those lines in the latest molecules that one has seen in the abstract form in congresses.
Johnny, thank you for this very elegant summary of this group of therapies. So we're now going to finish our discussion today. We're talking about gene therapy. So after 25 or 30 years of basic and preclinical evaluation, in the last 12 months, we've seen the approval for clinical use of a hemophilia A and B gene therapy. So they are arriving in the clinics now. And I'm going to ask Johnny to summarize what he thinks about where things are, how useful this will be, how many patients potentially might pick this up, and what are the things that we still need to be thinking about as we look at these first generation gene therapies. So Johnny, your thoughts about gene therapy?
Absolutely, David. I mean, like you, I know you've been working in this field almost all your life. I was particularly delighted to see at least 2 gene therapies being approved for patients with hemophilia, one for hemophilia B and the second one for hemophilia A. And of course, one needs to appreciate the fact that we are still using AAV-mediated gene transfer to deliver a functional protein to the liver in both of these molecules. And we have shown through proof of concept and in fact in real-world clinical trial that they both work. I think one needs to also accept that this is the first generation of gene therapy. In other words, there's a lot of things that we need to learn. In fact, to start off with, if we were to summarize where we are, we do know that they do work. In other words, you can produce a transgene-derived protein, such as a factor 8 or factor 9. We also know that, in fact, one can produce it to the level at which it is able to protect patients from bleeding. What is particularly exciting for me for gene therapy, Dave, is that there hasn't been a single case of neutralizing antibodies being directed against the transgene-derived factor 8 or factor 9, which is good news. Essentially, what it means is that we can, to some extent, try and forget about neutralizing antibodies when one's using at the higher level therapeutic armamentarium that we're using. The downsides at the moment, in fact, are many. They include the fact that many of these patients will have unexpected transaminitis that need to be managed. And the current ammunition we use at the moment is steroids, and the exposure to steroids is very, very variable. Some patients are on steroids for a shorter period, and others are on steroids for a very long period. We also know that no, we have not reached a stage where these gene therapies have been tried in adolescents and pediatric patients. We don't know if they will or will not work. In theory, one would expect that they should work. But we don't know if in a growing liver, one would have to give it again. Now, despite these huge advances with gene therapy and the potential benefit that gene therapy brings to our hemophilia community, we do know that there are limitations. And some of those limitations we are aware of. In other words, the known unknowns. There are other limitations that we actually don't know about. And in fact, in the context of gene therapy, even though the vector that is used, the AAV, is known not to integrate, we don't know what the long-term effect of having a vector in the body is in terms of the potential for integration going forward. In the human studies, we just have to give it time so that we can observe these patients over time. But we're particularly excited that gene therapy, at least in its first format, has arrived to the patients. And in fact, it has a lot of advantages rather than disadvantages.
So we're coming to the end of this discussion today. I hope we've indicated to you that the landscape of hemophilia therapy is extremely exciting. It's dynamic. A lot has happened in the past decade. And I think the other strong message that we need to give to you is that this hasn't finished. The innovation is going to continue for the next number of years. So the treatment of hemophilia is more complicated than it was 10 years ago, but it's complicated for positive things. This is personalized medicine for our patients, and patient choices are significantly more than they were 10 years ago. So stay tuned. I want to thank Johnny for an elegant discussion of this matter, and wish him well and a safe drive home in the snow. Thank you very much.
Thank you, David.